Welcome to AETCM, the emergency medicine channel. Today we will discuss about one of the important cardiac problem, that is rheumatic fever. Rheumatic fever can be sometimes they can involve many organs in our body, including heart. That's why it is called as rheumatic heart disease. Rheumatic fever and rheumatoid arthritis both are totally different entities. Rheumatic fever is a post-infectious arthritis leading to cardiac disease. Rheumatoid arthritis is an inflammatory immune-mediated arthritis that also can sometimes produce effects in other organs. So it is mainly occurring due to an autoimmune disease or immune reaction to an organism, that is group A streptococci, that mainly affects the respiratory tract. It's a beta streptococcal serotype, M types 3, 5, 18, 19, 24. These are different categories of this organism. They produce mainly like sore throat or inflammation in the throat. After that, patient develops joint involvement, heart involvement, subcutaneous nodules, and various other features of rheumatic disease. It's mainly occurring in female patients, and the main age group is 5 to 15 years. That is very important because when we are treating preventive treatment for rheumatic fever, the age group will be around 5 to 15. After that, we can possibly stop the preventive therapy in rheumatic fever. Now, this is a classical example for molecular mimicry. Molecular mimicry, you should understand that there is a virus. So, just imagine this is a virus. There is an antibody produced in our body against this virus. So, imagine we have a cell like this. For example, this is a heart cell that has got similar features of this virus. Then this antibody can even go and attach to this cell and produce damage. So these antibodies are produced to kill the bacteria or virus. Here, because of this molecular mimicry, the cell in our body also will have similar feature, can be can be a target for these antibodies, and that antibody may attack these cells. So it can like that it can attack, this antibody can attack our heart, joints, eyes, skin, etc. Okay, so this is an antibody mediated disease, but these antibodies are produced against a bacteria. These antibodies think that our heart cell, which is similar to this bacteria's properties, can also become target for these antibodies, and they try to destroy the heart cells or our joints, brain, like that. So this is an example for molecular mimicry. The most important problem in rheumatic fever, they have initially sore throat. After sometimes they develop other problems. Sore throat is mainly due to the streptococcal infection. From there, antibodies are produced against this bacteria. These antibodies go and attack our joints. So polyarthritis is present in around 60 to 75% of the cases. That is very important number, very high incidence of arthritis. What is the important feature of this arthritis? That also we should remember, because if you take rheumatic rheumatoid arthritis, they are mainly distal arthritis, and they are more both side involvement is very classical. But here large joints are involved, and they are migratory arthritis. That is very important. Suppose today patient is having high degree fever, right knee is involved. So another 5-6 days patient will have similar feature. Then right knee arthritis will subside. It will become left elbow. So that is very important. Then after 5-6 days this will subside. Then it will become left knee. So that's only an example. So this is a migratory type of arthritis, and they never produce destruction of joint. So they are not producing deforming arthritis like rheumatoid arthritis. Rheumatoid arthritis is a deforming arthritis. That means a joint can be deformed. Whereas here it is not a deforming arthritis. It's only an acute arthritis. Patient recovers from that without any deformity. That is very important. So very rarely patient can have deforming arthritis. This is called as Jacob's arthropathy. Okay, so that is also can occur, but that is very rare in rheumatoid arthritis. Now, what we have explained previously, again the antibodies go and attack the synovial membrane and produce damage there, inflammation there. With good treatment, it can recover back to normal. It will not produce normally a deforming arthritis or destruction of the joint like rheumatoid arthritis. That is the main difference between rheumatoid arthritis and rheumatic arthritis. Rheumatic arthritis mainly involves the larger joints. They are migrating, whereas rheumatoid arthritis mainly involves the smaller joints, distal joints. They are not migrating arthritis. So that is very clear. Now, the second important problem in rheumatic fever is carditis. Heart is involved. That is a pancarditis. If you remember the anatomy, you have three basic layers in the heart: myocardium, endocardium, and pericardium. So here all layers of heart is involved. Patient can have myocarditis, that is mainly clinically presented with tachycardia, and gallops can be there, S3, S4 gallops can be there. Soft S1 is a classical finding, and cardiac failure. So most of these patients will have tachycardia. So any patient who is having rheumatic carditis, that can have unusual tachycardia. So they are very high tachycardia when we consider the pulse. That is very important. So more than the routine response in fever, you can see. Now endocarditis is another major feature. Endocarditis means valves are involved. Mitral regurgitation and mitral valvulitis murmurs are very common. Mitral regurgitation produces a pan-systolic murmur in the mitral area. Mitral valvulitis produces an apical mid-diastolic murmur that is called as Carey-Coombs murmur. So anyway, any patient who is having high degree fever, joint pain, after some few days, if the patient develops a significant cardiac murmur, you should remember that that patient has gone to a phase of pancarditis, patient is having endocarditis. Another important feature is pericarditis. Patient can have pericardial friction rub, pericardial pain, small pericardial effusions, all can be there in pericarditis. ECG if you take, there will be in myocarditis, tachycardia will be there. Valvulitis, there may not be much problem in the ECG. It can be sometimes ST changes. Pericarditis, ST elevation, that is uniform ST elevation in all leads are classical finding. Now remember, it's a molecular mimicry. The bacteria is Streptococcus. There will be antibodies produced against this bacteria. These antibodies will go to the heart. They find that heart is similar to the previous pathogen, and they try to destroy the heart. Patient can have pancarditis. That is very important. Now, subcutaneous nodule is a late manifestation of rheumatic fever. Small, painless nodules are classical finding. They are over the bony prominence. This type of subcutaneous nodules can be there in rheumatoid arthritis also. There will be larger nodules that they can be painful sometimes. It is mainly seen in the extensor aspects of hand, feet, and elbows. That is very important, and most commonly they occur on the olecranon area. Subcutaneous nodules generally appear after the first week. That means less than 1 month of illness, usually in patients with relatively severe carditis. So that is very important. These subcutaneous nodules can be commonly seen in patients who is having carditis. That is very important. Now these are subcutaneous nodules. You can see here nodules. Subcutaneous nodules are classical feature of rheumatoid arthritis. and rheumatic fever, and it can also be there in rheumatoid arthritis, but they are larger nodules, sometimes painful. These are small painless nodules. Erythema marginatum is a skin manifestation of rheumatic fever. That pink rashes with clear center. That is very important. These margins are like wavy. They are called as serpiginous margins. They are also transient and migrating type of rashes. They are mainly seen in trunk and proximal part of extremities, but not on the face. It commonly occurs in patients with acute carditis. So here also, in patients with carditis, these features are very prominent. The lesions are also known as erythema annular, since the margins of the lesion usually continuous. That means it is like this. So margins are like this, serpentinous margins, and they are continuous. There is no break. Now these are erythema marginata. You can see the margins are continuous, but they are wavy, and central part is clear, more or less clear. You can see here central parts are clear. Now syndrome chorea, that is another thing seen nearly 6 months after infection. Sudden aimless irregular movement associated with hypotonia and emotional instability. That is very important. Tone is low, patient is having altered behavior and sudden aimless irregular movement. You cannot repeat the same movement after sometimes. So that is very important. This is called as syndrome chorea, or sometimes this is described by many examiners as bag of worms. So that is very important. That is mainly seen in the tongue. So behavior abnormalities are very classical along with this problem. It is mainly seen in female patients or girls. So recurrence of rheumatic chorea is not uncommon, mostly associated with pregnancy or oral contraceptive pills. And remember, ESR is mostly normal during syndrome chorea alone, but in rheumatic fever, normally ESR and CRP will be very high, but in a patient with syndrome chorea as a lone manifestation of rheumatic fever, ESR may be normal. Now this is syndrome chorea. See, it is otherwise called as Sen-Vitus dance or syndrome chorea. So you can see the movements; they cannot be repeated after some time. Or similar type of movements you cannot see. Now we have a diagnostic criteria for rheumatic fever, that is John's criteria or revised John's criteria. There are major, minor, and essential criteria are there. Carditis we seen pancarditis, polyarthritis. They are migratory, large joint involvement, non-deforming arthritis. Chorea we have seen what is chorea, erythema marginatum, and subcutaneous nodules. They are major criteria. Two major has to be there. Minor criteria: fever, arthralgia. Arthralgia means pain in the joints. Raised DSR, positive CRP or raised CRP, prolonged PR interval in ECG. These are all minor criteria. So two major or one major plus two minor, one essential. Essential is always, you can see here, essential raised ASO titer, anti-staphylococcus or titer. That is a titer against Streptococcus antigen. Positive throat culture, recent scarlet fever with rashes, evidence of antecedent group A streptococcal infection. ASO titer more than 250 Todd units, that is very classical. ASO more than 333 Todd units in children also can be diagnostic criteria. So two major or one major plus two minor plus one essential. Suppose the patient is having a carditis with migratory polyarthritis, you can make a diagnosis of possible rheumatic heart disease. Now, there are some relaxation of criteria, but I am not going to that details now. But remember, somebody is having a fever, like a young child with fever, arthritis, especially large joints like knee joint, with some previous history of like sore throat. You have to make a possible diagnosis of rheumatic arthritis, because the arthritis will be completely recoverable, but the heart disease, once occurs, that will be very dangerous. Patient can have permanent damage to his or her valves. Now, major criteria you can remember like this: cases, carditis, arthritis, subcutaneous nodules, erythema marginata, and syndrome chorea. Minor criteria: FAP, fever, raised DSR, CRP, arthralgia, prolonged PR interval, and previous rheumatic fever. So you can remember like that also. Now, how to manage a case of rheumatic fever? Bed rest is most important, because we know that whenever there is an arthritis or carditis, we have to advise the patient for full rest. You can give aspirin. That's a drug which is mainly used in heart disease to prevent the involvement of blood vessels. But here we are giving as an anti-inflammatory drug. 100 milligram per kg per day is the dose. It's a very high dose. So alternative drugs are naproxen can be given. That's an NSAID. Steroids, it is indicated severe arthritis and cardiac involvement. Prednisolone also can be given in rheumatic fever. Primary prophylaxis is very important if the patient treatment of streptococcal pharyngitis. When the patient is having streptococcal pharyngitis, you can prevent heart disease by giving a prophylaxis. That is primary prophylaxis. Penicillin is the most preferred drug here. We can give injection benzathine penicillin, 12 lakh units can be given, or penicillin oral tablets can be given. Alternatives are amoxicillin, cephalexin, erythromycin, and azithromycin. Now, secondary prophylaxis Penidur, that is after getting a disease, to prevent other problems or prevent recurrent infection, we can give secondary prophylaxis. Injection Penidur, that is benzathine penicillin, 12 lakh units. IM once in 3 weeks can be given, or oral penicillin also we can give, penicillin V 250 milligram BD, that is Pendits, that can be given. Erythromycin is an alternative if there is a penicillin and sulfa allergy, that can also be given in secondary prophylaxis. That is different from infective endocarditis prophylaxis that we discussed when we are discussing infective endocarditis. This is only rheumatic fever. So, rheumatic fever is a molecular mimicry against streptococci that involves the throat. It produces sore throat. From there these antibodies will go to heart or joint. They can produce damage there. In heart, they can produce a pancarditis. In joint, they can produce migratory polyarthritis, mainly in the large joints, and it can also involve other areas in our body, but main two areas are heart and joint. They can produce damage there. In heart, it produces permanent damage like MR or other valve involvement can be there. That may lead to infective endocarditis afterwards. So this can be prevented by prophylaxis. You have primary prophylaxis and secondary prophylaxis. Most important drug in prophylaxis is penicillin. Thank you.